Okay, welcome. This lecture is going to focus on blood for anatomy and physiology too, and we need to go over a lot of different aspects of it, so we're going to get right into it. Blood is the fluid portion of the cardiovascular system. The cardiovascular system consists of blood, the fluid, the conducting tubules, the blood vessels, and the pump, the heart. We will deal with several of these other aspects in subsequent chapters. Blood's function is to distribute oxygen, carbon dioxide, hormones, nutrients, metabolic waste, and blood cells. It is also involved in the elimination of local deficiencies or excesses of ions. It absorbs and neutralizes metabolic acids generated by active tissues. It will also defend against toxins and pathogens. And as well, it will stabilize body temperature. If we look at the components here, you can see where the pump is, the heart, the vasculature, which is both arteries, veins, and then, of course, in the local areas, capillaries, and then, of course, blood itself. As I've mentioned, these 5 points I strongly urge you to review and take to memory, okay? Blood is a connective tissue containing plasma and formed elements. The plasma is a liquid matrix. 55% of the volume of blood is plasma, but plasma is not some sort of water and that's it. It contains a variety of proteins, albumin, globulins, fibrinogen, as well as active and inactive enzymes. The content varies. Other solutes include electrolytes, such as the ions of sodium, potassium, chlorine, magnesium, calcium, as well as organic nutrients and organic wastes. The formed elements, that is, cells and cell fragments, are as follows. Platelets, which are also referred to as thrombocytes, are cell fragments. They're smaller. It's almost as if some people call it little bags of clotting medium. White blood cells are leukocytes. These are involved with immune defense, and they are the only cell of the 3 types that have a nucleus. Red blood cells, erythrocytes, are most abundant in the blood. They lack a nucleus, and therefore they have a limited lifespan of approximately 120 days. When we talk about hematocrit, that is the percentage of formed elements in a sample of blood, since red blood cells are about 99.9% of the formed elements, usually hematocrit is an indicator of the amount of red blood cells present. In packed cell volume, hematocrit, normal males will have a range of 40 to 54. The average is 47. Normal females is in the range of 37 to 47, the average being 42. The differences are due to androgens stimulating red blood cell production, and estrogens do not do that. If we take a look at this image, we see whole blood, which can be spun down to separate out the plasma, which of course includes plasma proteins, other proteins, and 92% of plasma is water, as well as the formed elements, which include platelets, white blood cells, and red blood cells. The key also, as we've mentioned a little bit in the last chapter, is that there are different types of white blood cells, as you can see, in part by the presence or absence of granules, as well as the shape of the nucleus. Properties of whole blood include that the blood temperature is about 38 degrees Celsius, or about 104 F, slightly above normal body temperature. Blood is 5 times as viscous as water. That is 5 times resistant to flow. Blood's high viscosity results from interactions among dissolved proteins, formed elements, and water molecules in the plasma. Blood is slightly alkaline, with a pH ranging between 7.35 and 7.45. Hint, hint, memorize that range. You need to know those numbers, and it's going to come back many times in subsequent lectures. The formed elements are produced by stem cells in the red bone marrow. Hemopoiesis or hematopoiesis. The formed elements of blood production. These hematopoiesis occurs, as I said, in the red bone marrow. And hemocytoblasts form from the hematopoietic stem cells. That's a mouthful, yes, folks. HSC. These divide into several different fates, or we want to say destinies. The lymphoid stem cells give rise to lymphocytes. The myeloid stem cells give rise to all other formed elements, that is, red blood cells as well as platelets. Now, there are these unique proteins, these hormones actually, called colony-stimulating factors. These are hormones released by activated lymphocytes and other tissues which spur blood cell formation. Now, erythropoietin, EPO, is released into the plasma from the kidneys. This hormone, EPO, travels to the red bone marrow to stimulate stem cells and developing red blood cells. When kidneys release EPO upon detection of low oxygen levels, this can be due to anemia, a decrease in blood flow to the kidneys, oxygen content in the air that decreases due to disease or high altitude, or damage to respiratory surfaces of the lungs. Hypoxia is the term used for low tissue oxygen levels. Now, if we take a look here in the center, in the medullary cavity of the bone, you have these venous sinuses here, and you have the red bone marrow. You start off with hemocytoblasts, which divide into lymphoid stem cells and myeloid stem cells. Lymphoid stem cells become blast cells, lymphoblasts, and then they become lymphocytes, and eventually lymphocytes. It is the myeloid stem cells that, upon stimulation by colony-stimulating factors, that can lead to the rapid production of myeloblasts and monoblasts, which the monoblasts will eventually go into the production of monocytes. The myeloblasts will divide and may either become eventually neutrophils, eosinophils, or basophils. Okay, all of these are granulocytes. Now, the myeloid stem cells can also divide and end up being megakaryocytes. And what is interesting with a megakaryocyte is it looks like it's almost like breaking up with a very large cytoplasm. And what that really is are small fragments of platelets which contain clotting medium. If you have the stimulation from EPO, the myeloid stem cells will eventually move into the direction of much more rapid production of red blood cells. Now, let's look at the platelets, otherwise known as thrombocytes, for a minute. This is how they might appear in a stained blood smear, basically kind of flattened out little structures. You do not have a nucleus in there. Their abundance, the average number per microliter, is somewhere in the range of 350,000, but they can be as low as 150,000 to as high as 500,000. They will clump together and stick to damaged cell walls, and they release chemicals that stimulate blood clotting. They are continuously being replaced. Each platelet circulates for 9 to 12 days before being removed by phagocytes, mainly in the spleen. Hematology is the study of blood and blood clotting tissues and blood disorders. Blood tests can detect disorders such as anemia, infection, and clotting disorders. A dyscrasia is a term for a blood disorder. Some can have systemic effects. When we talk about complete blood count, CBC, this is to determine the red blood cell count, the white blood cell count, the erythrocyte indices such as hemoglobin content, the hematocrit, the platelet count, and all of this can be done, yes, in 1 millimeter of blood. The term hemostasis is the attempt to stop bleeding. I encourage you to review the RBC tests and related terminology. You do not have to memorize all of these numbers, though. just to get somewhat familiarized with them, especially if you are heading in a nursing, pre-PA, allied health tract. Okay? Now, as you can see in this chart, the RBC tests and the related terminology, you can see hematocrit, hemoglobin concentration, mean corpuscular hemoglobin concentration, mean corpuscular volume, and RBC count and reticulocyte count. All of these you don't have to memorize, but you have to understand, why are they there? What do they help you to know? Well, if you have elevations of hematocrit, that could be polycythemia. This is a situation where you are producing far too many red blood cells, and so the viscosity of the blood gets greater, and that puts a strain on the cardiovascular system. But athletes try to do this, even for a short time, with the idea that enhanced red blood cells are enhanced oxygen carriers, and they give them a athletic edge in competition. If one has depressed numbers, you see anemia, and that can be caused from a variety of factors. Everything from radiation exposure to nutritional deficiencies. We'll go into a little bit of that later on. Now, red blood cells are the most common formed element and contain hemoglobin that transports respiratory gases, oxygen, carbon dioxide. RBCs account for roughly 1/3 of all cells in the human body. You want to note the dimensions and the shape and size. They are biconcave in shape, flexible cell membrane, important for the following reasons. They have a large surface to area to volume ratio. And the RBCs can form stacks, especially in the capillaries. This is what we get into when we call it the rouleau, the stack of red blood cells. So if you can picture a very thin capillary, it's almost as if they all stack up and slowly march along, one by one, next to each other, along that entire capillary length. Red blood cells have a certain flexibility. They can bend and flex when entering small capillaries. Red blood cell plasma is a meshwork of flexible proteins. Also, red blood cells are anucleate, meaning that they lack a nucleus. Here's what you see for a stained red blood smear. You'll notice that some of them look like donuts. The inner part where you can see light coming through is not due to the fact that they are having a hollow center, but that if you look at the thickness here, at 1.16 microns compared to the thicker edges at 2.85, light will pass through here a lot easier than on the edges. And so the center may get almost washed out, but it is truly there. Keep in mind, the large surface area to volume ratio is key to it being able to carry oxygen, as well as forming stacks and its flexibility. And you can see here the functional aspects of red blood cells. Here you see the rouleau. This is coming through in sort of a capillary, and they're all marching along in here. Same thing as over here. Now, none of the red blood cells have a nucleus. Just keep that in mind. So they flex and they bend and they squeeze and they pass through. But the key point is, after 120 days of this usually leads to wear and tear of the cells, and they are replaced rather than repaired. Hemoglobin consists of 2 alpha chains and 2 beta chains. Each chain is a globular protein subunit. Each hemoglobin chain contains a single molecule of heme, which is a non-protein pigment complex. The heme has an iron atom in the center of this complex. Oxyhemoglobin is when you have iron interacting with the oxygen molecule, and it produces a bright red color. Iron-oxygen binding is reversible and easily can dissociate. When you have deoxyhemoglobin, this is where you have a reduced hemoglobin and the color is more dark red. Now that's different, and it'll help you to understand. You know, we use for diagrams, arteries are bright red, and veins are blue. That is just for diagrammatic purposes only. You do not see that in real biological systems, but you can see a slight tinting difference between oxygenated blood, which would be somewhat more brighter red in color, versus deoxygenated, which is much more darker in color of red, by the way. So here we have this situation here. You have two beta chains, two alpha chains. Each one of these chains are a subunit making up a more macromolecular structure of hemoglobin. Each one of these chains has a heme group, as you can see right here, and in the center of it is the iron. Now, red blood cells are continually produced and their components recycled or eliminated. 1% of RBCs are replaced each day. Lifespan of RBCs is 120 days. Development of bone marrow requires iron in the form of Fe+2 and amino acids to synthesize hemoglobin. RBC maturation, you start off with pro-erythrothromboblasts. Then you convert over to erythroblasts, which stage depends on the nucleus size, cell size, and hemoglobin present. Then you have a normal blast, which sheds off the nucleus and becomes a reticulocyte. It contains about 80% hemoglobin. 2 days later, you enter the bloodstream. 24 hours later, you have complete maturation and resemble red blood cells. Tissue portions that have active red bone marrow include portions of the vertebrae, sternum, ribs, skull, scapula, pelvis, and proximal limb bones. Yellow bone marrow. Now, I've always taught red bone marrow is actively producing blood cells. Yellow bone marrow looks more like yellow chicken fat. It's inactive, but it can be converted. And it can be converted to red in urgent situations to increase RBC production. Macrophages in the spleen, liver, and bone marrow engulf the old RBCs and hemolyze them to remove the hemoglobin and cell fragments. From the hemoglobin, iron is stored in phagocyte, or it will be transported in blood by transferrin. This is a plasma protein. Globular proteins are disassembled to amino acids. Now, the heme is stripped of iron and converted to biliverdin. This has sort of a greenish color. It is eventually converted to bilirubin and transported in blood by albumin to the liver. Now, there's a situation where we have what we call jaundice. This is a yellowish discoloration of skin and the sclera of the eyes, and this is due to the accumulation of bilirubin, which is usually an indication of liver disease of one type or another. Bilirubin is excreted with bile into the intestine. What happens is after you've gone through all of this processing, you have to understand where these substances go to. In this case, the bilirubin will be converted in the large intestine bacteria to urobilins and stercobilins. This provides the yellowish brown color to brown color of the feces, okay? And you can see this as we talk about events in the bone marrow production. You go pro-erythroblast, erythroblast, the various stages, and eventually you get to the normal blast, which then does an ejection of the nucleus, the reticulocyte, and a short time after that becomes a full mature RBC. Now, since we've been talking about this, let's talk about what happens at the end of the lifespan of an RBC. The cells, old and damaged, are going to be assimilated, taken up by macrophages in the spleen, liver, and bone marrow. You have a strip down of the heme, the iron, the amino acids. The iron gets transported in the bloodstream by transferrin. Amino acids can be transported easily. And then the heme group is broken down into biliverdin and bilirubin. Now, urobilins are absorbed into circulation and excreted by the kidneys. This provides the yellowish color of urine. I just want you to be familiarized with a couple of terms here. When we talk about Hemolysis, that's the rupture of red blood cells. Hemoglobinuria. This is due to a failure to remove damaged red blood cells. Abnormally high numbers of red blood cells and their cell products, the alpha and beta chains, are excreted in the urine by the kidney. The urine will appear red or brown. Hematuria is the presence of intact red blood cells in the urine. And this usually occurs only after you have urinary tract damage. So, in the kidney, what we have the hemoglobin that's not phagocytized, breaks down, and the alpha and beta chains are excreted in the urine. Remember the bilirubin? Okay, so we have it excreted here with the bile. Bilirubin is in the intestine. The large intestine, bacteria start breaking it down, and you end up with urobilins, which are absorbed into the circulation and excreted out by the urine. Stercobilins basically are eliminated in the feces, and this accounts for the brownish color of the feces. Now, blood type is determined by the presence or absence of specific surface antigens on the red blood cells. So you want to keep in mind, this is where we're going to account for the ABO system on the surfaces of the red blood cells, as well as the Rh factor. Now, antigens are substances that can trigger a protective defense mechanism called an immune response. You remember that from last week's lecture. Antigens can be proteins or other organic molecules. Now, the plasma membranes of cells like RBCs have surface antigens. Blood type is determined by the surface antigens of red blood cells, and there's only really two major blood typings out of a variety of other antigens on that surface that we pay attention to. The Rh factor, and that is if you have the Rh factor, you're Rh positive, or if you lack it, you're Rh negative. And then the ABO system, types A, types B, and types O. A and B are dominant. O is a recessive trait. And then what happens is you have these interesting situations where you have type AB, which means that on the red blood cell, you have both A antigens and B antigens. This is due to the heredity principle of codominance, where A and B can both be expressed. All right. Now, the interesting thing also is that the blood types of one antigen will not have the same blood antibodies against that antigen. That would be autoimmunity. In other words, if you're type A and you've got antibodies against A, goodness gracious, you would be having your own immune system destroying your own blood cells. Rather, if you are type A, you have anti-B. If you are type B, you have anti-A antibodies. What if you're AB? You don't have either of those antibodies there. Okay. Now, let's talk a little bit more about this. Agglutinogens are surface antigens on the red blood cells. Now, gluten is antibodies to corresponding blood antigens. Agglutination is the clumping process that occurs when antibodies to the red blood antigen occur. So what happens is they have multiple binding sites, so they will bind together with several neighboring blood cells, forming sort of a clump. Now, since antibodies have multiple binding sites, this can occur where you're going to have lots and lots of antibodies binding to more and more multiple cells. This is where we get into the principle of cross-reaction. This is a clumping that's due to the exposure of red blood cell antigens with antibodies for that red blood cell antigen. The cells may then undergo hemolysis, in other words, lysing of the red blood cells. This happens, you will see it particularly with accidental cross-reactions. If a patient is treated for severe blood loss with the wrong blood type, what will happen is the blood put into them and their own immune system will basically start forming this cross-reaction clumping. Now, transfusion reactions, this is the cross-reactions, of blood types can be life-threatening because what you have to understand is that when you start having these clumps form, it's in essence you're forming almost like clots, and they can occur in large areas and small areas. But the worst is to have them occur in capillaries or veins or arteries for the heart or the brain, or, to a less degree, but just equally important, liver or the kidneys. So the blood donor and the blood recipient must be compatible to prevent such cross reactions. Here's type A. You see anti-B antibodies present, and notice that they're IgMs. They've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 binding sites. So they can really have basically, here you see this, you have 1, 2, 3 clumped together of red blood cells by just one antibody. This can lead to hemolysis, and so you have these cells lysing, breaking up, fragmenting as well. Now, type B, as I said, had anti-A antibodies. Type AB has neither. Type O has anti-A and anti-B antibodies in the plasma. Now, if you were to do a blood test, and unfortunately in labs, even when we have the real labs, we don't use real human blood because that's a biohazard due to blood-borne pathogens. So what we have is very nice reagents that do the same work for us. But let's say you were type A positive, came in, you put a drop of blood in, and then what they also do is they add a drop of anti-A. They also check it for anti-B and anti-RH. And what you can see here is anti-A has clumping here. So that means that you're type A. There's no clumping here, so it's like two solutions just hanging around. No serious clumping occurring, so it's not B. And you have clumping here for the anti-RH antibodies. Therefore, you are A+. I would encourage you to review these lower sides as you can see the clumping occurring. Let's just say that you were AB positive. You've got clumping for A, clumping for B, as well as clumping for the RH factor. Now, take it to the other extreme. If you were O negative, you would have no clumping for A, no clumping for B, and no clumping for the RH factor. Now, I'm not going to have you memorize the numbers. You can see that there is a distribution and it's spread in various amounts across the globe with various members of the populations. This is human diversity that exists, okay? And there is something that is very important, and that is called hemolytic disease of the newborn, HDN. Now, this is an RBC-related disorder caused by the cross-reaction between fetal and maternal blood types. Now, hemolytic disease of the newborn, otherwise known as erythroblastosis fetalis, is a reaction of the fetal Rh plus blood with mom's blood, which is Rh negative. So let's explore this for a minute. In the first pregnancy, mother's immune system is not primed for Rh plus antibodies. How you develop with the Rh factor antibodies is totally dependent on whether or not you're exposed to Rh plus antigens. If not, you can be Rh negative for the rest of your life and never have antibodies against the Rh factor. But during pregnancy, some of the antibodies will slip across the maternal barrier, basically the placenta, the fetal maternal barrier, I should say, and that's the placenta. And in some cases, at the end of birth, there will be some of the tearing of the placenta, which will allow fetal cells to mix with maternal blood cells. And this is when you have also another exposure. So upon exposure to fetal blood during pregnancy and at birth, this will sensitize the mother's immune system to produce anti-Rh antibodies. As I said before, the Rh blood factor is a dominant trait. If the father has it, then the fetus will have it. The second pregnancy, now here's the situation. Mother's immune system has been primed. It has anti-Rh factor antibodies. The maternal antibodies will cross the placental barrier and bind to the fetal blood cells, resulting in hemolysis of the fetal blood cell and would eventually lead to the death of the fetus. There is a solution to this, and it's called Rhogam. This is anti-Rh antibodies administered during the pregnancy, starting in roughly about 26 to 28 weeks. Now, during and after the first pregnancy, this is used to prevent anti-Rh antibody formation and to remove any fetal red blood cells that may have entered the maternal bloodstream. In the US, Rhogam has virtually eliminated HDN mortalities. And you can see this diagram here. Once you start having this exposure to the Rh factor, the immune system will begin to rev up because mom is Rh negative, has never been exposed to this. The problem is, after subsequent pregnancies, unless you have now Rhogam used, there is just a high mortality of the subsequent pregnancies. And it's very, very sad for the couples that are trying to have children. Now, the various types of white blood cells contribute to the body's defenses. WBCs, leukocytes, have a nuclei and other organelles, yet lack hemoglobin. Now, as I mentioned earlier, there are two types of leukocytes. Granular, otherwise known as granulocytes. They have an abundance of cytoplasmic granules. There are neutrophils, which are most common and are phagocytic. There are eosinophils, which are phagocytic, and they're abundant when you have allergies and parasitic infections. Basophils release histamine and other chemicals that promote inflammation. The agranular leukocytes, also known as agranulocytes, have smaller secretory vesicles and lysosomes. Basically, you're seeing monocytes, which become macrophages and will engulf pathogens or cellular debris. You have also lymphocytes. These are the cells of the lymphatic system and provide defense against specific pathogens or toxins. This is where you get the B cells and the T cells. Here is a stained blood smear, and you can see what you have here. Eosinophils, and you see some basophils here. You also have a monocyte, and you can have neutrophils. You also have a lymphocyte here as well. And of course, your red blood cells here. Now, there is a diagnostic tool that's used. It's called the WBC differential count. This will identify the types and numbers of white blood cell counts in the sample of blood. Basically, they use a stain called Wright's stain. It's a histological stain that facilitates the differentiation of blood cell types. It is classically just a mixture of eosin, which is a dye, and it comes off kind of red, and methylene blue dyes, which comes off obviously blue. But this is used in very many ways to help differentiate and identify effectively the different cell types, whether it's neutrophils, eosinophils, and basophils. If you see certain rises in some of these particular cell types, then you can start getting a clue that perhaps the illness is inflammation, parasitic infection, allergy. It could be because of number of infection from pathogens, etc. If we look at the agranular leukocytes, the monocytes here, notice the bean-shaped nucleus here, also an abundance of cytoplasm. Basically, these are produced primarily in the red bone marrow, and then you have the lymphocytes. Notice that there's a thin area of cytoplasm, but a very large, round nucleus. These will survive for months to decades, circulate from the blood to tissues and back, and are produced in red bone marrow and lymphoid tissues. These are the big cells used in adaptive immune response. Okay? They defend against specific pathogens or toxins. There are some shared properties of WBCs that I want you to be aware of. Now, all WBCs can migrate out of the bloodstream. Okay? Basically, WBCs circulate for only a short portion of their lifespan. They will be using the bloodstream primarily to travel between organs and to rapidly reach areas of infection or injury. Okay? You want to keep in mind also that as they are circulating, They come in contact, adhere to the vessel walls, and squeeze between the adjacent endothelial cells to enter the surrounding tissue. This process is called emigration or diapedesis. Now, all WBCs are attracted to particular chemical stimuli. This is chemotaxis, and this is a positive chemotaxis. Basically, the cell chemo components guide the WBCs to the invading pathogens, damaged tissues, or other WBCs. Now, neutrophils, eosinophils, monocytes are capable of phagocytosis. They can engulf pathogens, cell debris, other materials. Macrophages are monocytes, and they move from the bloodstream into peripheral tissues. Now we're going to move into the clotting response. Now this is a complex cascade of events that produces blood loss. Hemostasis is the stopping of bleeding. You're halting blood loss through the walls of damaged vessels. There are several phases that we undergo as part of the hemostatic response. First, vascular. This will last roughly 30 minutes after the injury occurs. It's dominated by the response of the endothelial cells, which will have this vascular spasm. This is a contraction of the smooth muscle of the vessel wall, so therefore it reduces blood loss. Then you have platelets that begin with attachment of platelets to the sticky endothelial surfaces, the basement membrane, and the exposed collagen fibers. So if you can just imagine kind of like a rough, ragged cut of a blood vessel and the surrounding area, the platelets begin to do their attachment, and they zero in on areas where they can form a good tight bond, exposed collagen fibers, basement membrane, some of the sticky endothelial cell surfaces. Finally, we get coagulation. A lot of times this does not start until 30 seconds or more after vascular damage has occurred. When we have coagulation, this is the blood clotting. It involves cascades of extrinsic, intrinsic, and common pathways. This is a cascade, so you have to think about it as like one activates another, which activates another, which activates another, which activates another. And these are all clotting proteins that play a particular role. All the pathways basically lead to conversion of fibrinogen to fibrin. As fibrin network grows, the blood cells and additional platelets become trapped, forming the blood clot. The proenzymes, now these are inactive enzymes, are converted to active enzymes. These are some of the enzymes that play a role in this cascade. They then activate blood clotting, pro-clotting factors, and activate them to being fully functional clotting factors. The three pathways I talked about, the common pathway, you start with factor X, which is also known as factor 10, because they're going to use a lot of factors that have Roman numerals there. When factor 10 is activated, prothrombin activation, it activates the prothrombin activation series. The extrinsic pathway is a little bit different. It will release tissue factor. This is known as factor 3. This is released by damaged endothelial cells or peripheral tissues. The intrinsic pathway is the activation of proenzymes exposed to collagen fibers at the injury site. So you have several different pathways that lead to a summation, which will be eventually a blood clot. Now, there are factors that play a role in this process. Endothelins. These are peptide hormones released by endothelial cells. They stimulate smooth muscles to contract and promotes vascular spasms. They will also stimulate the division of endothelial cells, smooth muscle cells, and fibroblasts to accelerate repair. Now, as we go through this, only what is in what I cover. Do not expect to know every one of the individual clotting factors and what gets activated, etc. Focus what's in my notes right here. The chemicals released by activated platelets include platelet factors that play a role in the blood clotting, platelet-derived growth factor, PDGF, which promotes vessel repair. You're also going to have a release of calcium ions. You will also have adenosine diphosphate, ADP, which stimulates platelet aggregation and secretion. The clot will begin to do retraction, and this is due to platelet retraction, and it begins to pull the cut edges together. You also will have fibrinolysis, which is the breakdown of the clot. You've got to eventually have this where it breaks down. And this starts by the activation of a proenzyme called plasminogen. It is activated by thrombin from the common pathway. Also tissue plasminogen, I'm sorry, it was a typo, but it's tissue plasminogen activator, TPA. And this is going to be released from damaged tissues. The activation of plasminogen produces the enzyme plasmin, which breaks down the clot. Before I go, I want to bring up one little interesting little fact here. If you've ever had blood taken in one of the blood tests and they put it into a tube, if you look carefully, some of the tubes will be marked EDTA. There's a reason for that. EDTA is a chelating agent. It binds to, in this case, calcium ions. With no calcium ions, you don't form any clot. With no clot, you have unclotted, freely moving blood. And that depends on the laboratory application, but that's one of the things that occurs. As you can see, we move from vascular phase, the vascular spasm, to platelet phase, where we have this platelet aggregation and the release of select chemicals here, to eventually the coagulation phase. The different pathways, the common, the intrinsic, and the extrinsic, and you end up with the clot. You eventually will have clot retraction, and you will eventually have it broken down in time. Okay? If you look at this, this is a very nice scanning electron micrograph, and the reason why I say this is because what you've got here is all the fibrin fibers trapping red blood cells here as part of that clot. Now, let's go over some blood disorders, and these can be classified by their origins and the changes in blood characteristics. Now, there's one other thing. Most of the time we see people saying, well, I need a blood sample, so let's get a venipuncture. Why do we do it this way? The reasons? The superficial veins are easy to locate. The venous walls are thinner than similar-sized arteries. The venous blood pressure is relatively low, so puncture wounds will seal quickly. If you did this with arteries, you face the fact that it would have a lot more blood leaking out from that puncture wound, which would be distress to the patient. Here's an example of a nice venous puncture here, and you can see how the phlebotomist or whoever took the blood sample got a surface vein, and you can see the tube filling up with the blood. Let's start off with blood disorders from nutritional blood disorders. Iron deficiency anemia. This is very, very common. Normal synthesis of hemoglobin cannot occur due to low intake of iron. The red blood cells appear microcytic. It's very, very small. Okay. Now, the other side of the coin is B12 deficiency, which leads to pernicious anemia. You see, the lack of B12 prevents normal stem cell divisions in the bone marrow. B12 is involved with synthesis of DNA and things like that. So the cells are made abnormally large, macrocytic. Finally, we have deficiencies of calcium in the form of calcium ions and vitamin K. This can result in impaired blood clotting. The liver requires an adequate amount of vitamin K for the liver to synthesize 4 clotting factors, including prothrombin. Congenital blood disorders. This is usually what you're born with, a genetic defect, etc. In this case, sickle cell disease. It is an inherited blood protein. The gene defect affects beta hemoglobin. The sickling of the blood leads to the capillary blockages and crisis. You see, what happens is that because of the defect in the beta hemoglobin, The hemoglobin, interestingly enough, will form long rods inside of the red blood cell, leading to the deformation of the biconcave round shape into more almost a sickle, or into kind of like narrow, almost convoluted round shape, not round shapes, but more cylindrical. And what happens is these can basically jam up in capillaries, causing blockages, and therefore what is called crises. The anemia can result as the system removes the defective cells. So basically, as the cells are being purged, you're not replacing the cells fast enough, and therefore the individual is anemic. Now, thalassaemias are a form of SCD, but beta thalassemia and other types of defects, they can be found not merely in African American populations, but they can be found in the Mediterranean and in the Middle East. Still, the defect leads to an inability to produce adequate amounts of blood subunits of hemoglobin. Hemophilia is an inherited bleeding disorder due to the reduced production of specific clotting factors. The individual suffers excessive bleeding that can occur with minor contact and can occur around joints and muscles. Now, blood infections. Bacteremia refers to bacteria which circulate in the blood but do not multiply. Viremia is when viruses are in the blood, they do not multiply. Sepsis is a widespread pathogenic infection of the body tissue. Septicemia is sepsis of the blood. This is where the pathogens are present in the blood, multiply in the blood, and are spread throughout the body. Malaria, though, is a mosquito-transmitted protozoal parasite that reproduces in both the red blood cells and also will reproduce in another form in the liver, leading to liver destruction and eventually to anemia as the red blood cells burst, releasing new copies of the parasite. When we talk about blood cell cancers, when we say leukemia, it's cancer of the blood-forming tissue. There are two major types. Myeloid leukemia, this is the presence of abnormal granulocytes or other cells from the bone marrow. Lymphoid leukemia is immature and abnormal lymphocytes appear in the bloodstream. Untreated, this is fatal. Then we have degenerative blood disorders. DIC, you need to get very familiarized with this. It's called disseminated intravascular coagulation. Bacterial toxins trigger coagulation, so conversion from fibrinogen to fibrin, in circulating blood. Now here's the problem. Due to rapid clotting and clot dissolving, small clots occur in small vessels and damage nearby tissues. You get basically anoxia because of no blood flowing into the organs. One of the targets would be the kidneys. But here's the other problem. Because you've gone through this rapid usage of clotting proteins, the liver cannot replace the clotting protein levels fast enough. This process leads to a reduced overall clotting, and uncontrolled bleeding will occur. Here you see normal and sickled red blood cells. You notice the sickling here? They're more cylindrical. Some of them may actually have a curve on them. Here is a mosquito biting a human, transferring the plasmodium, which is a type of protozoan, to infect the red blood cell. Here is an infant with septicemia from meningococcal bacteria. You can see how it's spreading. And then you have abnormal white blood cells seen in a blood smear of a patient with myeloid leukemia. Now, by the way, you notice the numbers here? This is not anything unusual. What is happening is you're making basically defective white blood cells at an astounding greater rate. And so instead of them being, once or twice you see them under the scope, you start seeing more and more. They crowd out the red blood cells. You have a defective immune system, and you have a system that is not going to be able to keep up with the demand of these abnormal white blood cells, which basically are useless, and they're going to compete for space, blood volume, with the red blood cells. Well, we've pretty much covered this, so here's what I encourage you to do. Peruse the chapter review outline on pages 653 to 655. Complete the review questions, pages 655 to 656. Complete review sheets on 636 and 652. In the next section, chapter 18, we're going to go over the heart and cardiovascular function. Have a wonderful day.